our conversation today.
Thanks very much, Jackie, and thank you all, and welcome to the third webinar in our first series of offerings by the Texas Consortium for the Non-Medical Drivers of Health. So a little bit about the consortium. It was founded earlier this year by Rice's Baker Institute for Public Policy and UT Health School of Public Health Center for Healthcare Data. And the purpose of the consortium is to improve health outcomes and reduce health disparities across Texas through investment by the health system in the non-medical drivers of health. A note on terminology, we are using the term non-medical drivers of health, or NMDoH, rather than the more familiar SDOH, because we're trying to align with the language that the Texas Health and Human Services Commission is using. We're so excited that they are actually working in the space, and if they want to call it NMDoH, well, we will too. So the reason we founded the consortium at this time is to capitalize on the momentum across the state around the integration of NMDoH into the healthcare delivery system. Increasingly, we're seeing health plans, providers, and health systems invest in non-medical interventions on behalf of their patients. We're seeing a variety of programs relating to food, and these programs use various screening tools and referral resources. You're going to hear about some of that today. Plans and providers are offering non-medical transportation and housing supports to patients to help improve their health outcomes. And the Texas Health and Human Services Commission earlier this year published its own non-medical drivers of health action plan. And it lays out a 4-year strategy for incorporating NMDoH into the state's Medicaid program, which, as everyone on this call probably knows, covers more than 5 million Texans right now. And just this month, HB 1575 was signed into law. This is the first bill that actually acknowledges the importance of addressing non-medical factors through the health system. And what this bill does is it will allow Medicaid to actually pay for doulas and CHWs to help pregnant women in the Medicaid program access non-medical services. And this is huge, as Medicaid pays for about half of all births in Texas, close to 200,000 a year. So the aim of the consortium, we're here to take this momentum and run with it. We're here to build a field of practice around the integration of NMDoH into the health system by bringing together organizations across the state who are advancing this approach through research, policy, and especially practice. There have been many conversations across the state about NMDoH. Usually, those of us who work in this space find our way into those conversations when people are talking about escalating healthcare costs or declining health outcomes or value-based payments or health system reform or public health or population health or health equity. So the Texas Consortium exists to provide a dedicated space specifically for those of us interested in accelerating the integration of NMDoH into the healthcare system. So here's what the consortium is doing this year, our first year. First of all, we're convening stakeholders through online webinars just like this one around 4 themes or affinity groups. And those 4 are food, community-based safety net providers, that's you guys here today, evaluation, and health systems. We held sessions on food and evaluation last week. And of course, today we're here talking about you community-based safety net primary care providers. We'll be holding additional sessions in September on each topic, and the specific content will be informed by your input during and after today's session. Second, we're building a user-friendly, searchable program index to catalog the NMDoH programs across the state. The program index will contain descriptions of programs with searchable fields, including who's offering the program, which drivers of health, populations, and health conditions are being addressed, the location of the programs, and the evaluation status of the programs. The reason we're building the program index is so that we can identify and then share information about the great work that's already happening in Texas. For those who work in the space, and especially for those who are just getting started, we need a single repository of NMDoH programs so people can learn who's doing what and figure out what works for what populations with what costs and what benefits. The consortium's program index, which is being beta tested right now, will be that place. For those of you in the webinar who are involved in these programs, please reach out to us so that we can include your work in the program index. Our final offering in 2023 will be an in-person conference, which will be held on the Rice University campus on December 8th. We've already secured Dr. Laura Gottlieb of SIREN, the Social Intervention Research and Evaluation Network, as our keynote speaker. We're also going to have Emily Centellis with us as a speaker. She's the lead at HHSC on implementing their NMDoH action plan. And we expect to have many interesting and interactive sessions on a variety of NMDoH topics. So stay tuned for registration information later this summer. This consortium will be what we want it to be. It's up to those of us in the field to suggest learning topics, research opportunities, and ideas about how to advance the field. During this session, you'll have the opportunity to give us your thoughts in the chat always and in breakout rooms. Thanks for beginning this journey with us today. Now I'd like to turn this over to our fearless opener for today's session, Jana Ube. Jana, along with Jolene Rasmussen and a small steering committee, have planned today's session and will lead the consortium's work during 2023 on community-based safety net providers. Jana is the CEO of the Texas Association of Community Health Centers, the group that all of the FQHCs in our state belong to, and I know so many of your members are on this webinar today, and they're already involved in helping their patients with NMDoH programs. Jana, the screen is yours.
Great. Thank you, Elena. And I also just want to thank you and your leadership for helping spearhead the development of this consortium. That's going to be incredibly helpful to our work in the community health centers and across the state and other safety net providers. And before I kick off and we get into our actual session, I wanted to quickly introduce all of our community-based safety net provider affinity group members. That's a mouthful. As Elena mentioned, Jolene Rasmussen is my co-chair. She's the Chief Strategy Officer at the Texas Council of Community Centers that do an amazing job in this space around the state. We're going to hear more about their work here in a minute. Also representing community mental health centers on our group include David Whedon, who is the Chief of System Finance for the Texas Council of Community Centers. Jenny Good, who is the CEO of Betty Hardwick Center in Tarrant County. Felicia Jeffries, who is the CEO of Gulf Coast Center, and Susan Garnett, who is the CEO of the MHMR of Tarrant County. And from the community health center world, in addition to myself, we also have Michael Glass, who's the Deputy CEO of CareVi, which is a community health center in Greenville, Texas. Amber Arthur, who's the Chief Operating Officer of the Community Health Development, Inc., which is a community health center in Uvalde. Budelia Ramon, who is the SDOH Director at CentroMed in San Antonio. Ana Maria Garcia Cortez, who's the Vice President and Chief Development Officer at CentroMed in San Antonio. And last but not least, Javier Garcia, who's the Director of Operations at Community Action Corp of South Texas, which is their main sites in Alice, Texas. So you can see we have a lot of variety in terms of sizes and locations of the representatives on this affinity group, which we thought was really, really important because each community has its own set of challenges, and each provider that's engaging in this work, it can be a very complex undertaking. And so we thought it would be important to hear from community mental health centers as well as community health centers that are also known as federally qualified health centers who historically have been engaged in some aspect of addressing non-medical drivers of health as part of our care model. A lot of that is in large part due to the patient populations that we serve and the mission of community mental health centers and community health centers. It can be, and so we thought it would be helpful to hear from providers that have been doing this for a while, and also are screening and referring very large numbers of patients to that need support in this space to be able to really help them improve their health care and improve health outcomes and their quality of life. As I mentioned, our two provider groups in this affinity group have been doing this for quite some time. And I think it is because of the patient population we serve. Just to give you a little bit of a flavor of the patients served by community health centers and community mental health centers. Community mental health centers, which you may or may not know, are local governmental entities, and their service area is the entire state. So 254 counties are covered by community mental health center services. They have 39 community mental health service centers that serve 687,000 patients, over 60% of whom are uninsured, and a whopping 88% of which are patients who live at or below 100% of the federal poverty line. And if you're not familiar with the federal poverty level, just to give you a sense of how low income that really is, in 2023, the 100% of federal poverty was $30,000 as an annual salary for a family of 4. So we're talking very, very impoverished and needy communities. In terms of the community health centers, or FQHCs, last year, community health centers served 1.7 million Texans. We have locations in 137 of the 254 counties in the state. 40% of our patients are uninsured, and about 66% of our patients are at or below 100% of poverty. So we're seeing very needy patients as well, and patients that have very complex needs. At this point, what I'd like to do is go ahead and introduce our panelists who are wonderful and volunteer to share some of their experiences. Every community mental health center and every health center have to address this issue slightly differently depending on their staff, their providers, the community, the resources of the communities, and their patients. And so we have a very diverse group of panelists that are going to share some of their insights in how they are screening their patients for non-medical drivers of health, as well as how they're making referrals and developing those community partnerships to be able to address those social needs of their patients. Our first panelist, and Jolene is going to be moderating this discussion. Our first panelist is Amber Arthur, who, as I mentioned, is the CEO at the Community Health Center in Uvalde, Texas. Ana Maria Garcia Cortez works at a larger health center system in San Antonio, Centromed. Jenny Good is the CEO of the Betty Hardwick Center in Abilene, and who's with a community mental health center. And Susan Garnett is the CEO of the MHMR in Tarrant County, where Fort Worth is located. She's also with a community mental health center. And Brett, I thought we were going to do a little Menti poll because we thought it would be helpful to see how many of the folks on this call are actually engaged as providers in some sort of screening or referral. And when we're talking about screening, I don't want to make assumptions that y'all know what I'm talking about. It's basically, how are we asking our patients about their non-medical needs that could impact their ability to access care or achieve good health outcomes? And when we talk about referral, it's how we provide information or make that connection between the patient and the community organization or social service organization that can help address a housing issue, a food insecurity issue, transportation, you name it. So we're going to be talking about screening and referrals. So if you could go ahead and thank you, Brett, for putting the code on there.
Yeah, no problem. Yeah, so thanks, Jenna. So we have the Menti poll up. You can see in the chat, there's the menti.com and the code that you can enter. And I'm going to start sharing my screen in a second so that you can see what the questions we're going through. And it's really only going to be about 4 questions. So this should be pretty quick. And just to get a good pulse on what everybody's doing currently, and you should be seeing responses. So you can do this on your phone or you can do this on the computer. And all you have to do is go to menti.com and enter the code that's at the top of the screen there, and you'll be able to go in. So we already have about 20 people on this first question. Are you screening for NMDoH? So are you currently doing it? Are you not doing it now, but you're really curious about doing it, or you don't think that there's probably an opportunity to do it for you? So those are the 3 kind of answer options, right? And so right now we're getting a ton of people that say that they're currently doing it, which is great. So there's a lot of folks doing screening. And I'm going to give it a couple more minutes to give some people some time to get in. I see we have about 30 some odd responses. So about half the group.
You know, Brett, I mentioned that community health centers as well as community mental health centers have been engaged in this work for a very long time. I know at least on the community health center side, even though many centers have been doing this work, it's not necessarily been formalized or expanded to meet all the needs of our patients. So I know, and I believe the community mental health centers are doing the same thing. We're always figuring out ways to do this work more effectively and more expansively. So even if some of you have been doing this work for a while, I know we're learning lessons as we go, and we're going to hear a lot about best practices that we're seeing in community health centers and community mental health centers in this space. So even if you're doing some work already, boy, there's some really great tools and new ways to do this work that I think you're going to be excited to hear about.
Yes, great. Thanks for that, Jana. Yeah, so that'll be in the panel coming up. So that'll be really interesting conversation. So I think we got enough people. We got about 40 people, and 80% are doing screening currently. So that's really good. So our next question is a follow-up to that, which is, what screening tool do you use? And you can just enter this as free text into the Menti poll, right? And so some people may be using Prepare, some other forms. Some people have custom tools. If you have a custom tool, go ahead and type that in. And we'll just let it should populate as people start to answer. Yeah, so custom tool, a lot of Prepare.
Hey, Brett.
Yes.
Can I interrupt for a second? Ken Yanda's has an interesting comment here. And while we're waiting for people to answer it, maybe Jana can talk to it. Jana, Ken says HB 1575 is going to require some degree of consistency in NMDoH screening for MCOs for pregnant women. He wants to know, how do we make sure that HHSC and MCOs come up with something that's workable for everybody? Do you want to speak to that, Jana?
I can take a crack at it, but I think we should open it up to others as well. That's a very good point. And that's actually one of the really challenging things, that we're using a lot of different screening tools. So on one hand, I think it's really beneficial that we're trying to get a little bit more uniform in at least the types of questions that we're screening. But we want to make sure that the state, when they're working on a particular set of questions or a particular tool, that it really will work for providers as well as our patients to be as impactful in the space as possible. So I know there's various advisory groups. And I know that some of us are very active in dealing with the state Medicaid agency and HHSC. So I know we're going to be meeting with them and talking about this. I would encourage other groups to do the same thing. But I think it's a very good point, and maybe we could leverage this consortium as a way to kind of consolidate our recommendations or help support a really powerful voice to be able to go to the state to encourage a tool that really makes sense, or questions that really make sense for our patient population and the types of providers. But I'm open to hearing from other folks.
Ken, you said you wanted to take a whack at the response?
Yeah, no, I just because in the bill language, there was an attempt to sort of say, and this is the screening tool that we'll use, and that was sort of not agreed to, and instead it was, we will have common measures or something like that. But I do think that, especially, for FQHCs or other folks that are, working with low-income pregnant women and stuff, it's going to be really important that we're all kind of on the same page. And I know that that's hard to agree on what that is. And so I just think, as Jana said, it's going to be really important for a number of people on this call to work and be part of those. Hopefully HHSC will have a number of forums to talk about this, and we'll come up with something that's not a Frankenstein monster, but instead sort of a standardized kind of format that everybody can use.
How's it looking, Brett? I'm sorry.
Good.
Go ahead, Julie.
Go ahead, Julie.
Just going to say that, another consideration, it may not be one tool, because when we were looking at the community mental health system, we were looking for things that were being required from other entities. So currently, SAMHSA with the CCBHC criteria requires screening for the SDOH. And they had proposed the American Academy of Family Physicians tool because it included the 5 elements that were necessary to be collected. So that's the usual, transportation, housing, food, but then also utilities and personal interpersonal safety. So I think that was part of the consideration. We were also looking at, currently for Joint Commission, it requires those 5 elements to be collected. NCQA, if many of you have any kind of accreditation with NCQA. So I think it's important to look at the other work, maybe some grant applications, other areas that you're working with, to really understand what tool is going to work that's going to meet these many needs. And I think then we can make a case. That was one of the reasons we wanted for our entire community mental health system to have the same tool, because it was easier to have that voice and then to be able to kind of make that business case and do some of the evaluation that we were talking about in the last webinar.
Great. Thanks, Jolene. This is a great conversation, and really appreciate those responses. So just to see what responses we're seeing on the Menti pool, a lot of custom tools in here. And as Jolene mentioned, there are some people that are using multiple tools to gather the information that they need for their community, right? So a lot of prepare, a lot of custom tools, and then some folks with multiple tools. So I'm going to move on to the next one, which is about referrals. So we have just 2 more quick questions. This is very similar to the first question, and it's just really asking, do you use NMDoH referral platform? So currently, if you're sending referrals, are you using any type of platform to do that? Or is it more of just an information exchange, giving people phone numbers and that sort of thing?
While we're waiting for the responses, Jolene, Keegan Warren has an interesting comment about the challenges of tools on the ground and what they're collecting. She says, the tools seem to treat each need as a one-size-fits-all. How do we lift up, leverage, and let lead the expertise of the social sector?
I think part of, our approach is really looking at, kind of that person-centered care. And even Janice talking about, because often we're dealing with patients that have multi, complex, whether it's physical health, mental health, substance use, conditions, needs. They also have the social needs. So there's a complexity and interaction that have to be developed. So you're really looking at those things and addressing what's important to that person, because sometimes the person is going to prioritize what their needs are, and how that's affecting their care. So I think, looking at the tools, the other thing you might think of too is many of the tools will say, screening annually. And what you might find with your clients or patient population is that many of these social needs change. Somebody can lose a job. Somebody can have some other kind of illness. There can be other things that happen. So there's a little bit of dynamics that occur. So if you're really trying to address what the need is, it's identifying that every time you see that person, it could be a different situation. There could be some barrier to them achieving their health outcome or even accessing the care. So that's part of it, the frequency, who does it, workflow. And I think our panel is going to get into a lot more of the detail of some of those considerations.
Great. Jessica, any other questions before we move on to the next one?
Nope, that's it.
Okay, great. So looking at referral, so there are fewer people doing using a referral platform than there were screening, but we have, most people say yes, but we have kind of a mix here as compared to the screening. So a lot more people are doing screening and a higher percentage, but a lot of people are curious about referral platforms, which is good, which is a good place to be now. And then last but not least, what platform do you use? So for those folks that say they're using a platform, we'd love to know what platform that you're using currently. Unite Us and Find Help. Yep, those are definitely common. Great. And when we get into the breakout rooms, we'll have a little bit more time to talk about this if you go to a referral breakout group. So Optum, that's a new one. I haven't heard of that one. That's interesting. So I think most of it's going to be Find Help and Unite Us. I think we only had about 15 people say that they were using a platform, so we're about halfway there.
I'll just, while we're waiting for a few more people, bring another comment to the team, because I think it's an important one here. Celerina Cervantes says that it's also challenging to integrate all the different screening and assessment tools used without placing an additional burden on direct care staff. So does anybody want to kind of talk a little bit about that dynamic?
That is such a good, I can take I'll take a whack at this one. I think that's such a good issue to bring up. I know that that's something that a lot of community health centers have struggled with. There are a lot of tools out there, and I think one of the things, unlike the community mental health centers, the health centers aren't just using one tool. Some of them use multiple tools or various tools. And so we've decided as a group that it's not practical at this point to have all the community health centers in Texas use the very same tool, but we do think it's important to have at least some consistent questions that all the centers are asking to be able to collect that data, so we can look at things at both a local level, but also at a state or regional level as well, to try to really identify some needs and hopefully even influence public policy as a result of that. And so, I think it is one of the things that you're going to hear in the panel discussion today. Each of the healthcare providers that's talking is using a different tool, a different approach. So it does kind of depend on what the patient's needs are, what the center, whether it's a community mental health center or a community health center, really think that would be meaningful in terms of gathering information from their patients and supporting their patient care. And it can vary. And so I don't know if there's any one perfect tool. Certainly there's not in the community health center world, but I think if we could get at least some consistency on some of the questions, so we're making sure that we're collecting that data, I think it's going to be really helpful in supporting population health moving forward.
And Jana, I was just going to quickly kind of build on that. And we'll talk about this a little bit more in the panel too. It's hard if you're just giving this as part of many, like you said, there's multiple screenings, multiple assessments. There's a burden on direct care staff. But the idea is, some of these screening tools for the SDOH or NMDoH are fairly short. And once you start seeing that by addressing these, you can improve that patient's engagement with their care, then you start getting some things like less cancellations, right? You start getting, better outcomes. You start achieving those, goals that we have as a system. And so then you get a little bit more of the buy-in that this is worth it. And I would say, even in talking to a patient or a client, this is where it's important that this is just not another form that we want you to fill out. This is just not another checkbox. we really care about this because we know this can impact your life. So we're asking you these things because all the help that we're trying to provide can be affected, can be impacted if your basic social needs are not being met and you're being challenged in any of these areas. So you're really explaining to the patient why it's important. And then I think you start seeing within your organization, within your providers, of the value. And once you start showing the value, I think then it's easier to understand that, yes, this is worth the time. This is worth the extra effort because I'm going to achieve these better outcomes.
Jolene, I think was a perfect segue into our formal discussion with our wonderful community mental health center and community health center representatives. So I'll just turn it over to you to get the conversation started.
Great, thank you. And, as we mentioned, we've talked about some of the work with the food instability group. The webinar was able to talk about very specific interventions that they were able to do related to food. And our evaluation talks about how are you addressing some of these social determinants, the non-medical drivers of health with health outcomes. But for those of us in the field, you realize you just don't go from point A to Z automatically. This is a process. And you have to kind of start and identify where you start and really build that out. So I'm going to ask just really to begin with Amber, and I would like her to share really kind of like from the leadership and organization, how do you approach and get buy-in and what is needed at an organizational, at a clinic level to start doing this kind of screening for social needs? Amber?
Sure. Just because there was a lot of introductions. So I am Amber. I'm at Community Health Development. We do service Uvalde, Laking, Campwood, Texas. So it's the Uvalde and Real County. And what we got from leadership is what we found, poverty is a highly, it's highly correlated with poor health outcomes. There's researchers on it. And from our leadership aspect on it is, in order to push our health outcomes and increase those outcomes, we needed to support our patients and what we are feeding to them. We always talk about self-management goals as a PCMH. Well, we're setting these goals, but are we asking the patient, do you know how to eat healthy? And if you do, are you able to buy healthy food? So in a leadership aspect, what we did and what we found was we're finding this trend, or how can we get the trend, and then therefore work in collaborations with other nonprofit and say, look, we have a need from our patients, and the only way we can get that is from screening them. Can we collaborate and find something that we can meet in the middle, whether it's covering costs on SWART, Southwest Transportation, we'll cover the charges, they only pay $1. Any of those types, the food bank, what can we do? Our leadership found if we can get the need that we're asking them to do and say, here's some help so we can get you where we need you, they're willing to do it. And that has been helpful for our community and our patients. And also, if we are wanting them to eat healthy, do they know how to cook healthy? So we go into, creating a happy kitchen for them, because we had to teach them how to cook because they don't know what a healthy meal looks like. We serviced 11,000 patients last year, 11,709 to be exact. And 7,752 of those were Hispanic. So you tell a Hispanic to cook healthy, well, beans and rice is nothing but calcium. And cholesterol. So having a happy kitchen, getting a fitness center, we do diabetic classes to say, this is where we want you, but this is how we can also help you. And so that's where our leadership found that it was needed and it was worth, especially, and it shows in our measures as well.
Yeah, Amber, I have one follow-up to that. One of the things that you mentioned, it's really having the leadership, having the leaders within your center providing that encouragement or setting those priorities and goals. And I know sometimes it's a challenge because while we see a need, there might not be at this time financial support to do that work, or the provider time, might not be billable. So how did you, was there like, your board involved or leadership, or how did you really get that true buy-in that then you could promote this across your organization?
So the board, we do have a great board, and a lot of buy-in was from them. We actually went for grants. What we did was our kitchen is from a grant. And then we got the staff. We noticed the supporting staff, once they have that support, we can go into another room aside from the provider and do the education that they need. And then therefore we get, and then we do follow-ups. It's not just, it doesn't stop there. So we implemented care coordination within the medical care team so they could follow up on what was said and what self-management goals were done at the time of the visit. What we do for our providers, it took a while because if you get a provider from a private sector, they come in, they only think numbers. And while productivity is important, our quality is also as important. We do a report to HRSA, and if our quality is there, we do get incentivized. So we try to bring it back to our providers and our care team as well and share, you did well, here you go, here's some incentive from us.
Great, thank you. And we'll come back to all of our panelists when we get through some questions. We're going to talk about some of the challenges and some of the successes that they've seen. But I wanted to ask Ana Maria, your clinic, your organization says, okay, yes, we're going to proceed and we're going to screen for these social needs. But then the question is always, well, who screens? Where do you screen? When do you screen? How often do you screen? So, what are some of those considerations and things that you had to work through just in addressing and identifying the right workflow?
Sure. Well, thank you for having me as part of this consortium. I did want to share a little bit about Central Med. Central Med is actually in San Antonio, and we are actually celebrating our 50 years of service this year. And in 2022, we actually have 30 clinic sites that serve San Antonio, New Braunfels, Schertz, Cibolo, and also the rural area of Somerset. We have over 850 employees, and last year we served 121,647 patients. So we're pretty big and growing. There's a big need in our community. Over 92% of our patient population fall below 150% of the federal poverty level. So we knew there was a big need and we needed to find a way to help our community. During the pandemic, we identified a lot of issues that were happening in the families, and everybody was struggling trying to pay their bills, in particular utility bills. So they were already asking us for help. So Dr. Gomez, our president and CEO, is the one that recommended that we start this program with the ARPA funding that we received. And so we established a coalition committee within our organization trying to find ways to serve this population. And we actually realized that creating a screening tool, which we call a patient questionnaire, to identify what is happening in the home of the patient when they come into the clinic. So when they come into the clinic, we first thought about having the clerk ask the patient the questions, what's going on in the home? Do you need assistance when food assistance, utility, housing, daycare, any things that they might need? But then we realized when we were doing the pilot that patients didn't feel very comfortable answering those questions in front of other patients in the waiting areas. So we took it away and gave it back to the medical assistant. And at first we had a lot of barriers because the provider and the medical assistant said, we're too busy, we don't have time to do these questions. But developing this committee with them in it, we had a physician, clinician, we included the nurses, customer service representative, and the clinic manager, and as well as our team to see how would this work? How can we make this happen? They got buy-in right away. They realized that patients are already asking for this help. They're already saying, do you know anybody who can help me pay my utilities? I need to pay this medication and I'm trying to decide, do I buy food or medication? And it's very important that we're able to provide the resources that they need because they rely on us for healthcare, and they feel that we should know what's happening in their household. And I think it's really working out for the nurse to ask them the question, What services do you need? The provider reviews it with the patient to confirm. So I understand that you need assistance with utility and you're having a hard time providing food. Is it okay if I refer you to one of our non-medical case managers, which is the term we use for our staff that helps with this department? And then the provider submits the referral through our electronic health record. Then a non-medical case manager will reach out, actually a care coordinator we have first will reach out to the patient to confirm that they still need this assistance, and then let them know when is the best time for the non-medical case manager to visit with the patient, communicate with them by phone or text or email, whatever works best, whatever method is best for the patient. And then they then complete the prepare tool and then refer them to different organizations in our community. It's been a long process. We did this pilot about a year ago, and we're really excited to see that it's working for us. It's not perfect. We're still tweaking. We're lucky in San Antonio to be part of the Alamo Area Community Network, which helps us to connect us to different organizations. But we're also looking at Unite Us because we feel that that is a great tool that can benefit our community. And we've grown the number of partners that we work with by reaching out to different organizations to see if they have the funding to be able to assist our patients with the resources.
Maria, thank you. And actually, I do have a follow-up question for you. So, as you said, you asked these questions and you mentioned briefly that you enter the information into your electronic health record. And I think that's an important factor because, often if you're asking these questions and it only exists maybe in a narrative form or in somebody's notes, but it's not accessible to people that can follow up, do the referral. We often refer to the closed loop referral where then you're getting the response if somebody goes there. So were you able to, for your questions, this is something that's readily available to people that work with your patients to access this information to make sure that the referrals are following through, so that's readily available to them?
Yes, actually these particular referrals are submitted through the provider, through the electronic health record, and they're sent only to our non-medical case managers. So that department sees all of them, and then the providers can actually go back in and see what happened to the referral. Did they get what they needed? Did they get a hold of the patient? That's another issue we're having, is obviously connecting with the patient after they said, yes, we need help, but then getting a hold of them has been a struggle. But when we do, we actually document in the notes how we were able to direct them or find the resource that they were looking for. So everybody can see it.
Thank you. Okay, we're going to move on. So we've kind of moved along our process now. We have, organizational provider buy-in. We have our screening tool. We've entered the information into our EHR. We're connecting people to resources. So I'm going to ask Jenny, and I know your service area is, multiple counties, but the idea is every community has different resources. And sometimes we're aware of what those resources are, sometimes we aren't. So when you're trying to address these social needs, how have you been able to engage the community, or how have you been able to identify and be able to better connect with the resources that are available?
Sure, great. So that's a good question. My name's Jenny. I'm here at Betty Hardwick Center, which is in Abilene, Texas. So Abilene is our most populated county that we serve. We serve, in addition to Taylor County, where Abilene's found, we serve 4 neighboring counties, which are far more rural and tend to have a lot fewer community resources available within those counties. And so one of the strategies that we have found to be true here over the years of working with our client population is that we have, because you heard at the beginning of the session when Jana described the population that we serve, many of our clients do live in poverty. They struggle with a lot of resources. So things like food, clothing, and shelter are frequently areas in which they need some additional support. And so when we're trying to treat them for serious or persistent mental illness, but they don't have a house, or they don't have food, or they have other health conditions that maybe also need treatment, it's really challenging to keep the focus on the mental health treatment when those things are going unresolved. And so in our community, we have found it to be very beneficial to be very plugged in with the other nonprofits. And so for quite a few years here, our center has been has a representative working in a leadership role with our area 211 agency. So in our community, 211 isn't just a telephone information and referral. They also facilitate a number of important work groups in our community. For example, they kind of are the hub, or they coordinate something called Basic Needs Network, which tends to be all of our area churches that do food pantries or clothing closets. And so they make sure that the information that's in the 211 database is well coordinated, but they also stay in regular contact with them. So if something changes, they can have that updated there. There are also groups that focus on special veteran services that operate in conjunction with 211. We have a West Texas homeless network that we're very involved in, and that also connects tightly to 211. So that when we have people who are living in encampments, not only are we engaged in doing some of the outreach and service delivery to those folks, but those other service providers are connected to that as well, so that we all stay fairly well coordinated, which is a challenge. Because in an environment where we're working, as you know, from year to year, grant funds change. People, even in some church or local nonprofit agencies, the direction or an area of focus might change, maybe very heavy in food pantries and clothing one year, and then the next year shift a little bit. And so it can be a challenge to stay abreast of all the current efforts that people are doing. But we have found that working through that group, and not just working from that group, but sharing with them actual examples and data about what our client needs are, where we're experiencing gaps in our community, and also can help not just our agency, but the community at large know where we need to pursue things like grant funding, or if a new nonprofit wants to start something, to be able to focus it a little bit more to address a gap.
You know, and Jenny, along those lines, you know, you talked about working with the other organizations and nonprofits and faith-based organizations in your community. In any of these meetings, do you engage with local government, be it city or county? Do they get engaged at all in trying to address the gaps that might exist?
So there are some city representatives in our community. Again, for the most part, Abilene is the larger community, but in our rural counties, county judges often fill a role of being a coordinator or a collaborator, bringing people together in their communities. But there are our county indigent healthcare groups sometimes will channel not only for healthcare resources, but also for food or housing as needed. So there are some government officials that are involved in those activities.
Thank you. And so along those same lines, you know, Jenny described her service area, and Susan Garnett, you know, she deals with, you know, Fort Worth, a much larger urban. And, you know, sometimes there's this misconception that if you live in an urban area, you have unlimited resources, and there are no issues and there are no gaps. But I wanted to give Susan an opportunity to describe, you know, the work that she's doing, because there are those ongoing needs, and who's doing what and when are they doing it and what's available. And I believe, Susan, you even were using kind of a platform that's been available nationally, but you've customized it for your area. So yeah, so go ahead and describe your work that you're doing.
Well, Jolene, I agree. I mean, we certainly do have some benefits in an urban community of having a lot of resources, but we also, those resources are there to face a lot of needs. So like everybody else, we struggle with not really having everything that everybody needs. The specific reference that Jolene is making is to our use of a platform that's developed by a company called Network of Care. And we've customized it here in Tarrant County and rebranded it as Tarrant Cares, but it's really a resource database that provides very rich resources in addition to resources on individual kinds of services, but also broader kinds of resources, information libraries and other kinds of things. And it's really a collaboration that we worked very closely with our community on, and the network of care system works very closely with 211 to assure that their resources are aligned and they're providing the same information, but it's a suite of products that is focused on people with mental health conditions, people with IDD, the prenatal to age 5 arena, or older people, adults with disabilities. So there's different products, veterans, homelessness, et cetera. So it has for our community been a good, just as Jenny talks about in Abilene, rallying opportunities for providers to come together to talk about the resources that they have and to make sure they're available to the community. We use that as one of those kinds of mechanisms. But I would also say that when I listen to Anna Maria talk about the whole piece around case management and how important case management is in identifying issues for folks, and then looking at where we can make those connections, that is so important, I think. And we have a system that has been really, that has, as you heard the statistics earlier, we deal with a population that has different types of disabilities, that is primarily a population of people who are resource challenged and deal with poverty and issues associated with poverty. And we know that that poverty brings health conditions as well as social kinds of conditions to the table. But the role of case management and helping us identify what's going on with somebody, help identify what resource needs people have, and then to make those connections in the community are incredibly important. And sometimes we take it on ourselves to kind of develop things, and sometimes we work with others. And it really sort of depends. I think about topics like food insecurity, and we're incredibly fortunate. We have a wonderful food bank resource here, as well as many churches and other kinds of social service organizations that provide food pantry, even within the schools, et cetera. But we also know that being a part of how your food is grown is important. And so we have increasingly in the last few years developed community gardens at some of our programs so that individuals who receive our services participate in the growing of food, participate in the gardening activities, actually, then pick the vegetables that they've grown and share them with others. And so, it gives our folks opportunities to, to have food that they've grown themselves and that they've really participated in, and that's fresh and good for them, because many of the people that we serve live in food deserts. You can live in a city and be as far from a grocery store as if you're in a far-flung rural area, because it's just simply hard for you to make it to that store. So we use really kind of a combination of factors to meet people's needs. So I'll stop there, Jolene.
No, thank you. And I'm going to open this question up to any of the four of you that want to respond. We deal, and many of you have talked about really trying to maximize and leverage those available resources within your community to address needs. And, we're looking at a future where there may be some financial sustainability, right? There may be a mechanism to pay for this. So I'm curious as to whether now you actually engage or utilize any for-profit type organizations, or if this is really something that only comes into play when there may be dollars available. So I just if any of you have an experience of working with other types of resources beyond just the kind of nonprofit.
So Jolie, the one thing that I would say is that we are beginning to see new players in the housing arena, where developers are seeing the opportunity that exists in providing stable housing for people. So I think we're just starting to see some of the other than nonprofit entities entering into some of these arenas.
And Elena had even mentioned I know there's everything from Meals on Wheels, and we talked about food pantries and other things that are available. And then there's players entering into the market like Uber Health and other things that want to provide transportation or want to do food delivery. So again, is this something that you kind of see and they've not reached the point of engagement, or they're just, kind of what is the feeling and really the kind of utilization you can have with these kind of groups now?
I know in San Antonio, we heard of a gentleman who's a very wealthy man in our community, who heard about some of the concerns that patients were experiencing, in particular paying for utility and so forth. And he actually reached out to another foundation and said, if I contribute a certain amount of money, how can you help us distribute this money to pay or help these families be whole? Now, of course, we're asking for it's going to take a lot of money, but it's one person who saw that there might be a way that if he could do it, then he's going to reach out to other business partners and see if they're willing to help out and pay for some items. Pay for some families to get their utilities paid for and not lose their housing. So I think there's ways in there. I think there's more people talking about it.
No, I agree. And I appreciate that. It's sometimes difficult. We've talked about the screening, and we've talked about, workflow, and we've talked about those community existing resources, because that's the first thing that you reach to, what's there. I think, Susan, has even mentioned before of, are we ensuring that we're using existing programs at the state level? The programs that the state has, are we checking to see that if somebody is eligible, that they're receiving those services? Because I think for, both of our groups, for the centers and the mental health centers, we are dealing with a very vulnerable population. And so those needs are, a little bit higher. I think one of the things that, we want to look to is that financial, again, sustainability, and Elena's talked about this. And so I think all of these conversations lead to that point of having that data available, looking to those outcomes, because improved outcomes can mean everything from reduced emergency room visits or inpatient stays or other things that are really driving some of these overall costs. So I think one of the things that, we look to is, how do you prove out the value? Because for many of our funders, especially those that are kind of in a different arena or looking to provide kind of financial support for the work, you have to make a business case. We see sometimes, this with even the managed care organizations, right? You're making the business case. So I think all of that goes to, to speak to the future and the work that we're going to do, but that doesn't really negate all of the work that has to happen right now to meet current needs and where we are in our communities. So I'm going to briefly go to each of you. And if you could just give me kind of one barrier that you think you had identified that you feel like you've had some success, or a success story in addressing something, just to kind of be able to share that. And Amber, we'll start with you.
Sure. So a lot of what we see was food security, and what our community health workers were able to do from the SDOH and getting that data and getting referred to them is signing up for mobile food banks that we have in the area. There's QR codes that they now provide where you can RSVP for it, working with our local food bank, our food pantry, and letting them know. Many individuals had no idea that just a couple blocks away at another school, there every Saturday, the first Saturday of the month, that there was the food bank of San Antonio that was coming and providing food for them. So that was a good success story. Another was a patient had no cell phone, and over here connectivity is huge, but also even getting a phone and getting a hold of the patient. So we were able to sign them up for free cell phone and free service through the Texas Lifeline program and Touch Wireless program that's out there. And the face that on that patient's face, I mean, the look on that patient's face was just incredible. And it's things from another incident where our individual is handicapped and couldn't get out recently, amputated leg, and needed a ramp. So working with a lot of students from the high school that needed social hours, built them a ramp. And it's just getting out there to the community and finding, okay, there is always something going on. You may just not know, and you just need to ask everybody. Even the last person that you think could help will be the ones to help. And I think with our county, we're pretty special because we do have an organization called Team Uvalde, and it is an organization that is with a bunch of nonprofits that meets once a month. And we just give a little outlook of what services we have, from Endeavors to Unitas to Community Action. We have over 60 partners that participate in this program, and we're able to say, we're able to have a listserv and say, you know, we have a patient that has a 1-month-old with no clothes or no food. We can send it out to the listserv. Church are involved. A lot of churches are involved, and they can say, come to Philip's Closet, we have what you need. Or even if it's a heater, they're able to provide that for us. So I think that is one of our hugest successes, being able to collaborate. And also we do, even though we collaborate with them, we have some barriers. I know our housing authority is part of our Team Uvalde, but our housing over here and where we are is very limited. If we have housing, there is a wait list, and the wait list can be up to 6 months. So I'm working and trying to figure out, okay, what else can we do? And just calling, okay, where are we in line now? Where, you know, we went from 10 to 6. So we're getting somewhere, but not fast enough.
No, I appreciate that. And that's great. It's always amazing what you can do in the communities and the people that pull together. Ana Maria, same question to you.
So we have been able to communicate with a lot of our patients who really needed food assistance, and we're able to connect them to our local food bank. And they don't realize this, but a lot of the church organizations really provide food pantries. And so when we make a connection that it's like right in their own neighborhood, church they may be going to on Sundays, but didn't know that they offered a food pantry, has opened up a lot of doors for them where to go. But also connecting them to those organizations that can provide assistance for utility assistance, just paying that one bill or restoring their bill. We have one particular situation where a family called needing assistance, and she had never been in a situation where she couldn't afford her electricity bill, and she needed something very quickly. And you know, we didn't think we were going to get her the help she needed that same day, because she actually lost the power already. But we were able to get it restored that same day, and she was so grateful. And sometimes you find those resources, and sometimes you don't. I mean, sometimes it's not as fast as we were able to get it for that particular lady. But the one story that I always touches my heart is this one lady who the provider was concerned that she was not getting her insulin. It's like, I don't understand. I keep prescribing this insulin and she's not getting it. She needs it. What's going on? And when we did the screening questionnaire, we asked her, what is it that's happening in your life that we cannot, you know, that you're not getting the insulin? And she indicated that she had lost her housing. She was in an efficiency now, and there was no refrigerator, and she didn't have a place to put her insulin. So what was the point in getting it? So our non-medical case managers reached out to a company that does actually, they do appliance repair. It's an appliance repair shop. Nowhere in our network of organizations to reach out to, but they went out of their way, reached out to them and said, would you all be willing to help us out with a patient who needs a refrigerator? And they were so kind, they donated the refrigerator and had it delivered to her home that same day. And we made a new connection, and we're going to be reaching out to them for other resources. But we touch so many lives, and we don't realize what's happening in the home and how it can improve their overall health. So our provider was super happy and is our #1 champion of this program after this situation.
Thank you so much. Okay, we'll mix it up. Susan, how about you next?
Sure. I love Anna Maria's story because I think it's so reflective of what happens in real people's lives every day. You know, when I think about what I hear from our patients occasionally who will write me a letter or an email about something that they appreciate, seldomly do I get a letter saying, gee, the doctor was wonderful and I love my medication. What I get is a letter that says, and I had lost all hope, and what you guys did was connect me with housing, employment, benefits, other healthcare services, et cetera. That those are the kinds of things that matter most to people. But I think, as in with Anna Maria's story, that what we see is that housing plays such a huge role in people's lives. To have a stable place that you know you belong to, that you can keep your things in. We can prescribe, like Anna Maria, very expensive and wonderful medications that if nobody has a place to keep them, they're not going to get taken regularly. And we know that. And so housing becomes so important. And what we know in our state is that it's certainly in urban areas, and I suspect the same is true in other areas, is that it's tougher to access housing, and housing is becoming less affordable, not more affordable. And in our world, frequently when people think about our services, they think about individuals with mental health conditions who are struggling to get access to housing. But we also see other folks, we see on a regular basis families who have maybe a child with autism who's maybe middle school aged and runs in the parking lot of the apartment building or makes loud utterances inside their apartments, and others have complained about it, and the family finds themselves evicted and out of housing. We see people who otherwise might be able to access housing, but because of a criminal history or a credit history, find themselves not able to access housing. And so we have to really think, what resources can we connect them to get them the IDs that they need, or to help get rid of those old unpaid tickets that are on their record or something like that. It can really help them. It's not just about finding the housing, and it's not just about finding out how to pay for the housing. It's what are the other things you need to do so that people really can take access, get the access to those kinds of benefits that really have the opportunity to change people's lives. If you can create some organization and some stability in people's lives, it makes it better for them as they access other services.
Thank you so much. And Jenny?
Yeah, I mean, these are all wonderful points. And, I was thinking as we were going around, which story to share. And I think that, a couple come to mind. All of them do have a large housing component. Just that's the reality of, part of our challenge. But I think about a family that was homeless and they were living in their car and really feeling pretty desperate about their situation. And in a day's time, we're really kind of escalating their interactions with agencies across our community, for everyone from 911 to every service provider they had tried to encounter. And finally, a housing coordinator who works here at the center kind of got in a room with them and said, what is it that we could do today? And what the situation was is that they were living in their car, had applied for a job, had been offered the position, but could not report to work because they didn't have the right boots. They didn't have the right boots to accept the job and go to work. So we were able to buy boots, and they were able to go to work. And that enabled them to be on the path to be able to move into housing in pretty short order. That was what was necessary. There are a few other examples that come to mind about people who continue to show up for services while they're living in an encampment or on the street. And they're really challenged, to keep appointments. Transportation isn't easy when you're living in an encampment, or getting across town if you're walking because you don't have a bus pass. Bus passes and transportation in our community are another very frequent barrier for people. And so that's a really big challenge. But I also think about clients in our community that have untreated serious mental illness and maybe are frequently in contact with 911 or someone from law enforcement in the community. And sometimes those folks have been challenged to trust people in the service system that they need to receive medication from or case management from. And so sometimes our path to putting that back on the right track is engagement, what we call engagement in the community. I have a community response team that might go make contact and take a water bottle to somebody, or sometimes a snack, and just build a relationship with them. But that food or a bus pass or whatever it is the thing that enables them to build some trust in a relationship with the service provider and come back in the door. And all of those things, as Susan said, are not the psychiatry aspect of their treatment. In many ways, that's easy. It's these other things that really are the harder challenges that we face. But when we're able to help people, to meet those needs, we're able to make some great strides with them.
Yeah, thank you so much. And Jessica, I'll just check with you. Were there any other outstanding questions that people had that we could address before moving on to the breakouts?
No, we don't have any questions. We've had a number of interesting reflections about while we have care agreements and established relationships with several different resource agencies, the community landscape is very fluid. And so they have to rely on their community workers to kind of keep out and people run out of funding, which is one of those issues. So we've had some good reflections, but no specific questions.
Well, great. Did I have anything that the panelists, I always want to give you an opportunity because I didn't ask the right question and you have something that you wanted to add, or have we covered enough for today's webinar? We good? Okay.
I think at this point, we'll turn it back over to Jackie, who's going to break us into some breakout groups for further discussion. Jackie?
So actually, that's going to be me. Thanks, Jana.
Sorry.
That's okay. Great. So we've got a lot of great participants still on the webinar today. We thanks for everybody to sticking with us, and we hope that you will stick with us in this next session. As Elena said, this is a new consortium, and the success of the consortium and the work that they do really depends on your input. It's really important to hear what your experiences are, what your needs are, and this provides guidance to the consortium on what their work ought to be going forward. So what we'd like to do now is break into different breakout rooms. We know that we've covered a lot of territory. So what we're going to do is we're going to have 4 breakout rooms to talk about screening strategies, and 3 breakout rooms that will talk about referral strategies. So if you all can look at the bottom of your Zoom screen on the little icon bar, there should be 4 little squares that say breakout rooms. Angie, if you can get those breakout rooms up. So that they will allow you to join a breakout room, and you can decide which breakout room you want to go to. We will have facilitators in those meetings who will take notes, and we will join each other back again in 15 minutes to close out the meeting. We appreciate everybody sticking with us, and please join a breakout room that is interesting to you. You have a slide. Rooms 1, 2, 3, and 4 are about screening, and rooms 5, 6, and 7 about referrals. So you should be able to pull up that thing and look at what room it is and join. If you can see how many people are in a room, if you're having a hard time deciding, try to pick a room that is not too crowded. I just want to say thank you to my amazing team. Thank you. We had a fantastic conversation on our room. Thank you very much. And thanks to everybody for coming back. We've got a really good conversation. We had a great conversation in our room. Why don't we just hear a quick snippet of sort of the topics that people were discussing in the room. So Becca, you were with the referrals group. Can you tell us just very quickly, what were the themes that came out in your room?
Yeah, let me share my screen so you can see some of the notes that I took. For the first question, there was a range. Someone from Harris Health talked about doing a combo of like closed loop referrals and then just more like passive ones, as well as helping patients directly with enrollment for different resources. And then others were like the platform for referral or the resource, and they kind of saw a bit of inconsistency between organizations and how they do referrals. For best practices, people talked about having 5 steps maximum, so simplifying the process as much as possible to improve patient user experience, and then having the most up-to-date information about the resources, as well as a comment about the Pathways Community Hub model, which is explained further over here. And then finally, someone asked a question about streamlining community information exchange and getting a better understanding of all of the resources that exist locally, and whether this Health Equity Collective exchange will actually be happening.
Great. Thank you very much. Katarina, you had a vibrant conversation in your room around screening. Do you want to share what they did in your room?
Yes, absolutely. Okay, so in my group, we had a really great, robust conversation, and when they are looking at screening, the biggest thing that they're screening for is, or the biggest struggle that they're having to screen is for financial support. And then second was childcare. Can be a bit tough to find funding, but there's a lot of things that they did screen for, so like transportation, affordability, accessibility, for language barriers, food, mental health and safety at home. So that was really great. And then when looking at the data and the ability to access it, we did have one organization that generates reports with their data. And then with that data, they go to their case managers, and the case manager will, reach out and get more details and then connect them to the correct agencies. And then another organization is starting to build out their program. So that's really exciting. Just getting the ball rolling on trying to get the data and connect people where they need to get connected to. And then lastly, the barriers that my group encountered when they're doing their screening is trust. So a lot of, people that are just that they're trying to help don't trust the provider. So, a big thing is to make them comfortable. And also there was a built-in bias from the person who's actually asking the question. So how do you frame the question? Needs to, try to take out your bias when you're asking it. So for example, Jessica said that they had, they call the doctor who is helping you with diabetes, the health police. So just trying to make them comfortable and gain their trust. Yeah. Thank you.
Great. Thank you very much. So we had a great conversation. Elena, we'll go ahead and turn it over to you to close this out for the afternoon.
Okay, thanks. We're all going to get back a little bit of extra time. By the way, there was a document about screening and referral resources. I think Jackie's going to drop it into the chat. And it's got some really good information on it, and you should hang on to that. Thank you all for a really robust conversation today. We're grateful for the input, especially for our speakers who shared their own stories. And we will integrate your suggestions into our work going forward. We really want your feedback about this webinar as well, and you'll get a short survey from us by email in the next couple of days. And we really do welcome any and all suggestions. This consortium is going to be what we make of it, so we need to know what you want from us so that we can prepare to deliver that. Please stay in touch with us. Our website is up, driversofhealthtx.org. And Jackie, our consortium manager, can be reached at jk90@rice.edu. Thanks again. Have a great rest of your day. And yay, NMDoH. Yay, NMDoH. Bye, everyone.
Thank you.
Okay. Great job, everybody. Well, your speakers left too.